did 6 months of medicine AAU last year, and in that time, towards the start of the year, actually, had a chat with Dr. Clark about the needles that we're using for LP, because I think still quite a lot of people have been using the cutting point Quinky tips, but these days we really ought to be using atraumatic needles. So this slide, which hopefully people can see, is from a BMJ kind of rapid recommendation article that was from, I think, 2018. But this isn't a new thing, really. For probably, I think, at least 10 years that have been these atraumatic needles. Quick basis is that it's the end of it isn't a hole. The hole is on the side, and it's a pencil point rather than a sharp thing. So it makes less of a hole in the dura, so there's going to be less of a CSF leak. It's going to give people, hopefully, less of a headache afterwards. The actual technique is not really much different. You just use an introducer and then to kind of cut through the skin and put it into ligament to start with, and then shove the actual spinal needle in through that. It is a very slightly different technique. So if someone's used to the old needles, it might take a little while to get used to them. But for someone, if there's any guys who haven't started doing LPs yet, you'll never know that it's any more tricky than the other ones. And actually, the success rate is pretty much exactly the same. No more people taking more attempts or taking longer to actually get it done. With that said, the needles that we have now got in are these ones. So these are Sprott needles, which means, as I said, that there's a hole just on the side of the tip rather than on the end. In terms of accessibility of these, currently they're in the cupboard in SDEC. And we've got some which we're hoping to get put, well, in the storeroom. Unfortunately, AAU doesn't have its own storeroom, so it's down the end shared with A&E. But also, hopefully, we're going to get a trolley actually in the AAU area, just so that they are accessible when people want them. The extra thing to know about these needles, which have got the yellow bits on, is NR fit. So it means that these connectors will only work so that manometer and these needle ends will only work with each other with the yellow connectors. The idea of that is that you aren't going to accidentally put a normal syringe onto the end and give someone something intrathecally by accident. It's unlikely, I guess, in the medical situation, but that's kind of where things are moving forward, just to reduce any chance of errors like that. We have me and Fraser Wiggins, one of the anaesthetic consultants, and made a video which is on the intranet, which I'll try and get the link emailed out to, but just kind of explaining, a bit more detail about kind of why we're using them, and then a bit on the technique of how to do it. There's a link on there if anyone's interested of the actual meta-analysis and stuff with the basis. I think it's like a 60% risk reduction of the complications, which do mean people staying in hospital for longer, needing extra treatment. So overall, it's a good idea, and it is cost effective. I'll flick through the thing quickly just so you can see what's in it.
Then we feel for the iliac crest.
Fraser's excellent demonstration.
And then we feel downwards, and this denotes the position of L3. If you feel you're still on the spine,
a few little tips as well.
You don't necessarily have to take the introducer all the way out. You can just push the skin.
But yeah, people can watch that sort of in their own time. What was I going to say? We will also at some point hopefully be doing some more just kind of training sessions with a mannequin, probably based on AAU. And at some point I'll send out a survey just to see how much interest there is in that, and try and get that sorted. But yeah, that's all I had to say. I just wanted to kind of get people aware of what we were doing, and make sure people are actually using these needles because we have got them, and that's what's best for the patients. All right, I'll hand over to Mo. But any questions quickly? Crack on.
Yes, that's visible now. Thank you.
Okay, so good afternoon, everyone. I'm Mohammed Ali, one of the specialty doctors from neurology department at Conquest. Can you hear me clear, please?
Yes, you're coming through loud and clear.
Thank you very much. So today I would like to present a case of acute painful paralysis. I think this case might be known to some of you. So Mr. PM is a 55-year-old farmer who was previously fit and well with no significant past medical history. His symptoms started at the 7th of May 2020 with severe lower back pain and bilateral lower limb pain of sudden onset which awake him from sleep. He sought medical advice, seen in A&E twice, and was discharged on painkillers. His condition continued to deteriorate and worsen, and his pain was increasing despite regular painkillers. On 12th of May, he presented again with increasing pain associated with headache, retroorbital pain, and vomiting. He was admitted to AAU and was found to have bilateral lower limb weakness with power grade 3 out of 5. His reflexes was sluggish. He got equivocal planters and intact sensation. He was still suffering from very severe lower back pain and limbs pain as well. So at this point, what else would you like to know? If any of the audience would like to say something, feel free, please. Any differential? Okay, so he had routine blood test which came back normal, had a CT head which was reported as normal as well. The plan was to discuss with neurosurgery department who requested an MRI spine. Obviously, the concern was about Coda-Equina syndrome since his main presentation is a lower back pain with lower limbs pain and paralysis. MRI whole spine done, however, due to patient not tolerating to lie flat for a long time, sagittal images were not done. Radiologist reported mild degenerative changes which cannot explain the patient's condition. So at that point, no neurosurgical cause was found. Anyone wants to know more information? Any thoughts? Okay, so the patient was referred to neurology and his assessment, same story again, lower back pain, started sudden onset associated with lower limb pain. After 5 days, starting to develop bilateral lower limb weakness with power grade 3 out of 5. At this point, further two information was obtained from his history. The first one was that at 2 weeks before the onset of pain, he had his first COVID vaccine. And at the same time, he had a meal outside, takeaway meal, and developed gastroenteritis-like picture. His lower limb examination confirmed weakness with a power grade 2 out of 5 with depressed reflexes, but his reflexes were still obtained. His planters remained equivocal and he had intact sensation. His abdominal reflexes was absent. motor level up to xiphisternum. At that point, upper limb examination showed bilateral mild weak hand grips with power grade 4 out of 5, and again, present reflexes and intact sensation of upper limbs. Face and cranial nerve examination showed mild weakness of the left orbicularis oculi with power 4+ out of 5. Fundoscopic examination was normal. Frequently, this patient, a diagnosis was of acute flaccid ascending paralysis following an infection versus COVID vaccination was considered. The patient was planned for intravenous immune globulin and CSF analysis and serum antiganglioside antibodies. He started his IVIGs. CSF came back showing cytoalbumin dissociation with protein level at 2.44. Patient received IVIGs, and despite having IVIGs, he continued to deteriorate and required ITU admission on day 2 due to severe bulbar involvement and respiratory failure. At that point, he developed complete flaccid quadriplegia with bilateral lower motor neuron, 7th nerve palsy, and bulbar palsy. During his ITU admission, he developed severe autonomic disturbances in form of fluctuating blood pressure, pulse rate with documented arrhythmias on his ECG. It was showing a ventricular runs of ventricular bigeminy. He also arrested 2 times during his ITU admission and developed lower respiratory tract infection. He received full dose of intravenous immune globulins for 5 days with no improvement. Decision was made to wait for 3 weeks until he reached plateau. After that, he was transferred to Princess Royal Hospital ITU. He had a nerve conduction study which confirmed an acute motor sensory axonal neuropathy, which is a subtype of Guillain-Barré syndrome. After that, the decision was made to have a plasma exchange. He had 5 sessions of plasma exchange and was transferred back to Conquest Hospital. He remains ventilator dependent. Unfortunately, he showed very poor recovery and required gastrostomy and remained on ventilatory support. He stayed as inpatient for nearly 4 months. And during this period, he was completely ventilator dependent, and he was referred for rehabilitation. So a diagnosis of Guillain-Barré syndrome was established. And now I would like to talk briefly about Guillain-Barré syndrome. Definition: it is an acquired demyelinating polyneuropathy, heterogeneous group of disorder associated with immune-mediated attack on peripheral myelin sheath, resulting in clinical weakness, sensory loss, and areflexia. Ascending paralysis may develop acutely within days or subacutely for up to 4 weeks, reaching a plateau from which the spontaneous resolution of neurological deficit occurs over weeks to months. In the majority of cases, an infection trigger can be recognized, example bacterial, viral, or most commonly respiratory tract or gastroenteritis, which will have subsided by the time of neurologic symptoms began. Recently, a post-COVID Guillain-Barré syndrome was reported. Cytomegalovirus infection are the most frequent identified viral trigger of Guillain-Barré syndrome. The clinical picture of is either respiratory tract infection or non-specific flu-like illness. CMV-related Guillain-Barré syndrome is most common in younger patients and leads frequently to facial and bulbar palsies, respiratory insufficiency, and unusually severe sensory loss. Another cause is Epstein-Barr virus infection associated with Guillain-Barré are again more frequent in younger population. The neuropathy occur in the early course of acute infectious mononucleosis, and sensory symptoms are prominent here. Another cause is HIV-associated Guillain-Barré syndrome, which can occur in early phase of HIV infection, especially at the time of seroconversion. A lymphocytic phagocytosis in the CSF should raise concern. Campylobacter jejuni is the leading cause of gastroenteritis, is recognized as the most frequent bacterial pathogen for Guillain-Barré syndrome. Patient experience fever, abdominal cramps, and diarrhea, which was exactly what was happening with our patient. Mycoplasma pneumonia is the second most common cause bacterial pathogen linked to Guillain-Barré syndrome. Also, idiopathic Guillain-Barré syndrome is described. Clinical presentation. Guillain-Barré syndrome typically begins with paresthesia in toes and fingers, which are followed within hours to days by a progressive leg weakness and variable paralysis of the arms, legs, face, and oropharynx. The evolving disease is often accompanied by back pain that may precede the actual paralysis by several days. Most frequently, the weakness is first noted in the legs, but can also begin in arms. Very occasionally, paralysis may develop in a descending pattern, affecting initially facial and pharyngeal muscles, then spreading to intercostal muscles and diaphragm, eventually becoming generalized. Occasionally, paralysis can become established within 24 to 48 hours from onset of symptoms. More frequently, weakness develops gradually over several days, reaching a peak within 2 to 3 weeks, or at most 4 weeks. Here is a summary of the patterns of presentation. So starting from the left-hand side, this is the classical sensory motor presentation, which is usually an ascending type of paralysis. Second one is a pure motor weakness, which is again can present as ascending pattern. A third one is a paraparetic or paraplegic Guillain-Barré. So the patient will only have sensory motor paraparesis, which will going to be confined to lower limbs only without any symptoms in upper limbs or cranial nerves. Another type is a pharyngeal or cervicobrachial Guillain-Barré, which is usually started as a descending type of weakness, starting with a bilateral facial palsy and upper limb sensory motor symptoms. Fifth type is a bilateral facial palsy with only sensory symptoms involving all limbs. A sixth variant is a pure sensory variant, and this is often missed as casual peripheral neuropathy presentation. Another variant, which is again rare, is a Miller-Fisher syndrome, which is one of the descending Guillain-Barré variants, characteristic with the triad of areflexia, ataxia, and ophthalmoplegia. The last type is classically descending Guillain-Barré, which will start from the face, bulbar muscles, upper limbs, diaphragm, and then lower limbs. And during this particular pattern of Guillain-Barré, patient might have reduced level of consciousness, and it was frequently called brainstem encephalitis, but it responds nicely to intravenous immune globulins. Diagnosis of Guillain-Barré diagnosis is generally clinical, looking for certain features as above, with laboratory testing for antiganglioside antibodies, CSF looking for evidence of cytoalbumin dissociation, and electrophysiological studies to confirm this. There are many criteria which can be used to diagnose the condition, but overall clinical features of gradual evolving neurology following certain pattern with consideration of ruling out mimics and neuronal shock are the mainstay to support the diagnosis. So as to rule out neuronal shock, you will need to have imaging of the back or brain, depending on the level of the weakness. Electrodiagnostic studies performed at the presentation and serially for follow-up. In AIDP, which is acute inflammatory demyelinating polyradicular neuropathy, the early diagnostic findings are indicative of multifocal demyelination. Demyelination will be manifested as slowing of nerve conduction and partial or complete block of conduction in motor fibers are the cardinal electrophysiological findings. So you need to remember that demyelination pattern is a slowing of the nerve conduction, and axonal loss is reduction in amplitude. Sensory nerve recordings from median and ulnar nerves are usually similarly affected, while those of sural nerve are often still normal. And this is one of the hallmarks to diagnose Guillain-Barré electrophysiologically. In later stage of the disease, the signs of complicating axonal degeneration will become evident. Finding of reduced amplitude of motor and sensory action potential, and by recording of abnormal spontaneous activity on needle EMG examination. Treatment strategies. Intravenous immune globulins at a dose of 0.4 gram per kilogram body weight for 5 days, and plasma exchange 200 to 250 mils of plasma per kg body weight in 5 sessions are equally effective in treating Guillain-Barré syndrome. Intravenous immune globulins and plasma exchange, they carry a comparable risk of adverse events, although early studies showed that plasma exchange was more likely than intravenous immune globulins to be discontinued. As intravenous immune globulins is also easier to administer and generally more widely available than plasma exchange, it is usually the treatment of choice. Prognosis of the disease. Most patients with the Guillain-Barré syndrome, even those who were quadriplegic or required mechanical ventilation for long period of time, showed extensive recovery, especially in the first year after the disease onset. About 80% of patients with Guillain-Barré syndrome regain the ability to walk independently at 6 months after disease onset. Despite the generally positive prospect for patients with Guillain-Barré, deaths occur in 3 to 10% of cases, most commonly owing to cardiovascular and respiratory complication, which can occur in both acute and during recovery phase. Long-term residual complications are also common and can include neuropathic pain, weakness, and fatigue. However, recovery from these complaints may still occur even after more than 5 years after disease onset. Recurrent episodes of Guillain-Barré syndrome are rare, which is affecting 2 to 5% of patients with Guillain-Barré, but this percent is still higher than the lifetime risk of Guillain-Barré syndrome in general population, which is 0.1%. Take-home message. I've noticed that this gentleman, initially, the examination was only confined to his lower limb, and no upper limb examination or cranial nerve examination were obtained. So always complete your neurological assessment regarding the patient symptoms, assess cranial nerves, symptoms and sign of meningeal irritation, fundoscopy, motor, sensory examination, sphincters. Sphincter, you can always ask for a bedside bladder scan, cerebellar signs, and extrapyramidal signs. Always think about 3 questions. What is the lesion? Where is the lesion? And what is the most likely cause?